So the final session of the day, I thought what we will do is, we have already discussed the spinal cord, that has been done, that's been discussed threadbare. Now we also discussed about, we gave you just an overview about hemorrhagic stroke, about subarachnoid hemorrhage. So now we will just touch upon ischemic stroke. So basically, mechanical thrombectomy now has become a class 1 indication for patients with acute ischemic stroke and large vessel occlusion. How do we choose those patients which are going to have a good outcome after mechanical thrombectomy? And the most important thing is the management of the reperfusion injury. The most important part of that management is to avoid it. So how we avoid the reperfusion injury and how we choose those cases, that is the crux of this discussion. If you look at the big 7 mechanical thrombectomy trials that have been published since 2015, you find that the number needed to treat has gone down and down and down. And now the number needed to treat is somewhere at this region. That means you need, in a meta-analysis, it has been shown that you need to treat 2.5 patients for 1 patient to have a MRS of 0. That means if you treat 5 patients with a large vessel occlusion, you can be sure that 2 patients will go home with MRS 0. In the other 2, there will be definite subgroups, but this number is comparable to the number that is required in a patient with acute ischemic infarct with mass effect to be saved by decompressive hemicraniectomy. So for decompressive hemicraniectomy, the number is 1.7. For mechanical thrombectomy, it's 2.6. We have seen lots of patients with large infarcts, malignant infarcts, and we know that if they are decompressed in time, invariably they survive. The same holds true even for mechanical thrombectomy in acute ischemic stroke. So if mechanical thrombectomy for 5 patients, you can be sure that 2 patients will do very well. Out of the other 3, 1 to 2 patients may not improve or may improve but not to MRS 0. 1 patient will not do well. So basically the focus of this discussion now is going to be choose those other 3 patients. Which are those 3 patients who are not going to improve? Because you do a complex procedure, you do a long procedure, and at the end of it, the patient does not do well, does not look nice, does not feel nice. So can we choose those patients from the beginning so that we counsel them appropriately, that the chances of you recovering are less, the chances of you recovering are more? So that is what we are trying to discuss. We have known for quite some time that there is a lot of convergence between the Tiki score at the end of mechanical thrombectomy and the modified Rankin scale. We have seen that. For example, if the Tiki score is grade 2B to grade 3, the chances of patients with good functional outcome keep on increasing. The chances of the patients going into MRS 3 or above keep on coming down. So we know that if we get a good reperfusion, that is a grade 2B partial filling of almost 99% of the vascular territory, to grade 3, that is complete perfusion, the chance that these patients are going to do well increases exponentially. So here lies the convergence between the Tiki score and the MRS. Is that always the case? Not always. In certain situations, you have a lot of divergence between the Tiki and the MRS. For example, if you produce a grade 2B or a grade 3 reperfusion in 100% of patients, we cannot say 100%, at the best of hands, we say around 90 to 92%. As of today, the hardware that has developed and the techniques that have developed, Mukesh will be showing you all those, the chances that we are going to achieve a Tiki 2B or a Tiki 3 is in the range of 90%. 85 to 95, in that range, 90% ballpark figure. But if you take this entire subgroup of patients and you follow them up, you will find that the chance of these patients developing a MRS 0 to 2, that means independent daily activities, is around 55 to 60%. So you have a 90% Tiki 2B, Tiki 3, but you have only a 60% MRS 0 to 2. So this is where the divergence comes. So better reperfusion definitely means a better outcome, but not necessarily in every case. So the 30% is what we are targeting at. How can we pick up those 30% so that we can work harder on those patients? 91%, 91% versus 63%. It was known long back, in fact, as long as 440 BC, that it is impossible to cure a severe attack of apoplexy and no easy matter to cure a mild one. This is in the Hippocratic writings. Stroke was known even at that time, and this is what he had mentioned. And approximately 2,500 years from that time, or almost 3,000 years from that time, we still have not cracked the stroke code completely as of now. What is the reason? Maybe it is because we are looking at targets which need not be looked at in detail. Maybe we are maybe we are not looking at something. Let us see what exactly happens. How this thought process came about is by looking at certain patients. This is a patient, this is one of the patients he was a young patient. He is a young patient rather. He is around 25, 27 years old, and this is again a 5 to 7 year old case. This patient had come to us within around 6 hours of having a large artery occlusion. This is the second day scan. This is not the scan done at admission, that I have not shown. This was a case, a perfect case was for taking up for mechanical thrombectomy. This was a perfect case for us to take up for mechanical thrombectomy. We recommended mechanical thrombectomy for this patient, but he refused. But he said that he needs to stay in the hospital. He will stay in the hospital, but he wanted only medical management. He did not want to go back home. He did not want a mechanical thrombectomy. So obviously we got an informed consent for doing the same. And then we treated this patient with conservative management. And this was the scan which we saw on day 3. On day 3 to day 4, we can see that the entire left MCA is thrombosed over here. You can see that there is a significant amount of edema and mass effect that is developing in the MCA territory. You can see that the lateral ventricles are completely effaced out. You can see that there is counterclockwise torsion of the brainstem. You can see that the opposite perimesencephalic cistern is also completely obliterated. But at the same time, this patient remained conscious, even at this stage. At this stage, we offered this patient a decompression. Again, he refused. He gives it in writing that I don't want any surgical procedure. Then we follow this patient up. And over the next 10 to 15 days, this patient remained conscious throughout. The edema starts going down. The midbrain torsion starts getting reduced. The perimesencephalic cistern on the opposite side starts opening up. And what you see basically here is a lot of edema in the white matter. The gray matter looks like it's relatively well preserved. Yes, we'll show that angiogram in the end. So this patient, despite having all the predictors, all the so-called predictors for having a bad outcome, ultimately at the end of the week or 2 weeks or 3 weeks of treatment, this patient walked out. This patient walked out of the hospital and he did very well. In fact, this was his CT scan at follow-up at around 1 month. And we see that definitely there are some small infarcts in the white matter. The gray matter is relatively well preserved. The brain volume is relatively well preserved. So this tells us that apart from a closed artery, a closed MCA, there are definitely multiple other factors which come into play. And it is a composite of all these factors which decides what outcome the patient is going to have. Yet another patient. This was again one of our old cases. This is 2015. This was immediately after the Mr. Clean trial and all those trials had come out. We took this patient up this patient presented with a hemiplegia, left side with aphasia. We did the angiogram. We found that this patient had an occluded MCA just distal to the, just distal to the temporal branch. Subsequently, we did a mechanical thrombectomy. This was one of the first mechanical thrombectomies that we had done in my center after I had come back from training. So we did the mechanical thrombectomy. We had a TICI-3 flow. Everything was fine. The patient was absolutely fine. The patient improved. The hemiplegia disappeared. The aphasia improved. We were mandatorily doing a CT after 3 hours and then subsequently on the next morning in the early phases of our program. So we did the CT at the end of 3 hours, and we found that the entire gyral system, the entire insular cortex, along with the superior frontal, the inferior frontal gyrus, as well as the parieto-occipital areas, they were the areas which were expected to be ischemic and infarcted. These areas are getting a lot of staining. In the beginning, we did not know what this was. We thought it was hemorrhage. But if you look at it very carefully, it is only along the gyruses. It is only along the gyral lines. When we did a Hounsfield of this, it was around 130, 140 Hounsfield units. So that told us that this was basically contrast which was getting stuck in these areas. Now, patient is doing absolutely fine, but he has contrast which has leaked out from the arteries. Now, that is an artery. That is the vein. The contrast has leaked out from the arteries into the interstitium, but has not yet reached the venous system. That's why it's getting stuck over there. So we were trying to understand, and then we started seeing this phenomena in subsequent cases, and we knew that this is all contrast and this is not blood. So the anxiety factor started coming down, but we still were not sure how exactly this is happening. Then, as the number of thrombectomies increased, we started finding that there were some patients, for example, this is the scan of the same patient. If you remember this picture, staining along the insular cortex, staining along the frontal operculum, staining along the temporal operculum, and staining in the parieto-occipital area, in the parietal area, not occipital. Occipital is completely spared. Now, if you look at this, this is the follow-up of the same patient. The same patient, the areas in which the contrast was getting held up, in the same patient at the end of 1 week, all the contrast is gone completely from here, but it has left some amount of cortical laminar necrosis, not a complete necrosis, but a significant amount of necrosis, but this patient makes a very good functional improvement. Compare this with this patient in whom again we had a left M1 occlusion and we had done the thrombectomy, and in this patient we did not have any of this kind of staining as well. We just had some staining at the caudate head, and this patient comes back to us with MRS 0 with only a tiny infarct in the caudate head. This was a third patient where we had again done the thrombectomy. I'm showing you all left MCA cases. We had again done the thrombectomy, but 24 hours after the thrombectomy, this patient developed a massive hemorrhage, and ultimately we could not save this patient. So what was the difference between the pre-thrombectomy assessment of these 3 patients, the immediate post-thrombectomy assessment of all these 3 patients, and the ultimate outcome of all these 3 patients? This is what we need to concentrate on, and that's when we get the answer so as to what is driving this. It is always definitely not bad news. Supposing you choose a patient carefully and luck is on your side and on the patient's side, when you do a mechanical thrombectomy, sometimes nothing is left behind on the diffusion. There is a complete diffusion reversal at 24 hours. This is in fact at 12 hours. And the patient does absolutely well with maybe 1 or 2 very small tiny infarcts in the white matter. So we will see how exactly we can choose these patients as well. Before trying to understand what is happening, we need to understand the normal circulation and the microcirculation of the brain. What we need to understand is, whenever you inject contrast in a leptomeningeal artery, for example, you are injecting contrast into the internal carotid artery. When you inject contrast into the internal carotid artery, This contrast opacifies the perforators, the basal perforators, the lateral striate arteries, the medial striate arteries, the recurrent artery of Hubner if it's present. Then it goes subsequently onto the leptomeningeal system, and it supplies the entire convexity from outside. This ramifies on the leptomeningeal system, goes through the capillary barrier, and then ultimately starts converging into these tiny, thin structures. These are the deep medullary veins. From the deep medullary veins, this flow converges at the edge of the ventricle, and from there it exits via the deep venous system. So normally, the arterial supply of the human brain is from the convexity, from outside, and the venous drainage is from the deeper structures, from inside. Blood has to traverse this entire area, and then it reaches its outlet. In between, when we are injecting this entire artery with contrast, whatever you see in white are the vessels, but whatever you see in black, this is not empty space. This is the area where the contrast has not been allowed to enter. So all these black spaces are the areas where the blood-brain barrier is active. Now the blood-brain barrier is basically made up of the podocytes from the astrocytes, the foot processes of the astrocytes. Then it is made up of the podocyte cells per se. Then it is made up of the tight gap junctions, and finally the endothelium. So as long as this microcirculature is intact, the size of your contrast molecule is such that it will not go through the gap junctions into the interstitium. But the moment these gap junctions do not work, you will have the contrast which is leaking into the interstitium. So the moment we saw this, we realized that in a post-thrombectomy situation, when you see contrast staining, no contrast has been given in the CT. This is the contrast that has been used during the mechanical thrombectomy. Now, when this contrast is getting stuck in the brain, outside the blood-brain barrier, this can be used as a surrogate marker to look at the degree of blood-brain barrier dysfunction. So post-thrombectomy CT, the best case scenario will be where you have no contrast staining. And the worst case scenario where you have extreme contrast staining. So then we started looking at the patterns of contrast staining in patients who undergo mechanical thrombectomy. I don't have that image here, but I'll come to it and I'll show it to you later. So we realized that we have reached a situation in which, depending on various factors, for example, the lack of collaterals, the duration of occlusion, longer the occlusion, longer the blood-brain barrier dysfunction. So the more the contrast extravasation, the more is the degree of blood-brain barrier leakiness or disruption. We will come back to that. You should also realize that as far as the arterial system of the brain is concerned, the outer 2/3 are supplied by the leptomeningeal angioarcade. But as far as the venous drainage is concerned, the inner 2/3 are drained into the deep venous system. So the cortical venous system drains maybe only 10% of brain parenchyma, whereas the deep medullary venous system drains almost 90% of the brain parenchyma. When you do a mechanical thrombectomy, if the entire blood-brain barrier is intact, you will inject the blood, you will inject the contrast in the ICA, MCA, ACA. Then this blood or contrast will go to the convexity, and then it will come via the medullary venous systems to the edge of the ventricle, and then it will go out via the thalamostriate system, the septal veins, and the internal cerebral vein. So at the end of mechanical thrombectomy, if you see that your angioarchitecture is intact, and at the same time, your venous outflow is via the deep venous system, you can make a reasonable assumption that the entire blood-brain barrier is still intact. Sometimes what happens is you inject blood after a TK3 reperfusion, the blood goes into the leptomeningeal system, but from the leptomeningeal system, you do not see any opacification of the deep venous system. But you have a venous drainage. Entire blood is coming down up to this area and then going back into the cortical venous system. That is when you know that your blood-brain barrier has been disrupted. So those are the patients who are likely not to do well. So we will see some examples of that. Before we go into that, again, you have to know that the angioarchitecture of the neopallium, the neopallial angioarcade is just around 5 to 8 million years old. The archipallium is basically supplied by the choroidal system. This is almost 200 to 250 million years old. And the paleopallial system is the one which supplies the olfactory and the para-olfactory cortex. That is at least 400 million years old. So the ability of this area to understand, to tolerate ischemia is much different than the ability of this area to tolerate ischemia. So whenever you have an MCA occlusion or IC occlusion, you have to pay attention to the situation of the perforators. Because the perforators, the choroidals, these are the vessels which dictate the functional outcome. Also, when you take the patient up for mechanical thrombectomy, this was a patient who had a dissection in the neck. But when you do the injection, you find that this patient is having an excellent collateral circulation. So this is again a situation in which it is better not to meddle around with the occluded artery, just leave it alone. Because the aim of this lecture is to try and tell you how to decide which patients to pick up for thrombectomy. A patient has come with an occlusion, you have done an angiogram, you find excellent collaterals, leave the patient alone. You have 8 levels of collaterals, starting from the vertebrobasilar system, coming onto the pericallosal system, and then ultimately onto the leptomeningeal angioarcade, which can supply the brain in the event of an occlusion. So please remember to look for the collateral circulation also. One more important thing which is genetically determined, which probably was the case in the first example that I showed you, is the degree of PL collateralization. The degree of PL collateralization, all 3 cases are cases of MCA occlusion. All 3 cases are cases of M1 occlusion. In this, you can see that the collaterals are just coming below the watershed zone. So these are poor collaterals. In this situation, you can see that the collaterals are coming almost up to the frontoparietal operculum. So these are grade 2 collaterals. These can go either way. These can either create ischemia, or these can probably, if you keep the BP up, suffice to keep the brain alive. But these are grade 3 collaterals. Grade 3 collaterals in which you are almost reaching up to the occluded MCA. So again, in these situations, this also tells you that probably the occlusion is a chronic occlusion. It is an acute and chronic occlusion. Brain has had time to develop collaterals. Again, these are situations in which probably you can wait and you might not want to meddle with the occlusion that you see at the bottom. Because the moment you start having retrograde flow and you open this vessel from below, but you're not able to open it completely, the antegrade flow might not be able to supply this area, but it will definitely push the collaterals back. So in that case, again, you'll have a problem. Sometimes in certain situations in MCA and ACA strokes, we find that even when there is an M1 occlusion, you can see that through the ACA, you have neopallial connections, and then the artery is retrogradely filling. These are not collaterals, these are neopallial connections. So in these connections, if you have these connections, and if the distal brain again is being opacified very well, you might want to consider what you exactly want to do in this patient. Another case, left MCA occlusion, we did the thrombectomy, we opened the vessel. the behavior of the collaterals is very, very dynamic. At the beginning of the case, when we started this case, the collaterals were probably like a grade 1 collateral that you saw in the beginning. They were looking as if they cannot opacify the entire space, the entire area. But as the procedure progressed, we have done one pass and we have opened one trunk of the MCA, we can still see that the collaterals from above are trying to come down. But the moment you open the vessel completely, you see that again, the ACA-MCA watershed has been pushed back. So the collateral zone where the MCA and the ACA are going to meet is not a static point. It will depend on hemodynamic differences. If you have an MCA occlusion, probably with time, with a few hours, this collateral is going to reach up till here. If you can definitely open the vessel like we did, again the collaterals will be pushed back. So any patient in whom you have good collaterals, it just tells you that you have time, you can still open this vessel, and you can still improve the functional outcome of this particular patient. We know that if we look at the CT angio source images, you can look at collaterals. You can look at, when you look at the source images in axial or in coronal orientation, you can see the collaterals that are coming up till almost the insular cortex. So the moment you have a CT angio done for a patient with an acute ischemic stroke, make sure that you also look at the source images, the axial cuts. And that will give you an information so as to how much time you have to open this vessel. Another important part, this is a patient with moya moya. This is a patient whose entire one half of the brain is living on a single perforator. This patient has complete occlusion of the supraclinoid ICA, except for one lateral striate artery, which is going up and which is arborizing into all these branches and is supplying the entire neopallium. In this case, the neopallial supply is from inside to outwards. The flow has been completely reversed, but that is nature's way of taking care of this problem. Why I'm showing this slide is, in the future anticipated advances of endovascular therapy for acute ischemic stroke, we do believe that the angiogenic potential of the ventriculofugal segment of the lateral striate artery is a very important and a very promising candidate. This can be targeted with angiogenic factors, and like you do cytoprotection, you can probably do angioprotection, and you can inject it intravenously so that at least you have some amount of angiogenesis. It has been shown in mice models, in rodent models, that this angiogenesis starts after the giving of an angiogenic factor within 5 minutes. So you take 5 minutes to 10 minutes, 10 to 15 minutes to open the vessel, but at the same time, if you were to inject these angiogenic factors, this again will be an additional functional outcome. Yet another important thing that determines the outcome of patients with left. When I talk about large artery occlusion, now I am restricting my discussion to the anterior circulation. I'm not generalizing these points for the posterior circulation because the rules are different. So whatever I'm saying, I'm talking about a large M1 occlusion or a carotid T occlusion. All these principles are for those two situations. Now, looking at the plain CT images that are available to us, if we see a hyperdense MCA sign, it is not just enough for us to say that there is a hyperdense MCA, which means that the entire artery is occluded. What we need to see is, what is the disposition of this clot? For example, the occlusion can be just in the proximal most segment of the M1, just proximal to the perforator origin. The occlusion can be in the mid segment of the M1, just at the point of the perforator origin. The occlusion can be in the distal M1 at the insular cortex, just before the MCA bifurcation, after the origin of the perforators, or it can be in the entire MCA. Now, entire MCA occluded is 1/3 of our cases. Distal segment, mid segment, and proximal segment in MCA occlusion is around 10% of cases. So we can automatically understand that technically these procedures will be shorter. These procedures will be easier to suck the clot out. But the moment you have a hollow MCA occlusion, the chances that you're going to suck the clot out with a single aspiration or a stent retriever is less. Therefore, in these patients, again, with a large clot in the MCA, the outcome does not seem to be so favorable as it does in these three situations. Hardware and techniques, so Dr. Mukesh will be discussing with you. Now we are in the 3rd generation of stent retrievers. You can do just a stent retriever. You can do just a stent retriever combined with suction, or you can do just a suction. It does not make a difference. Use whichever you are confident with as a first pass maneuver, and it is a matter of personal preference. So Dr. Mukesh will tell you more about it. So now, having said that, these are the kinds of clots that we extract from the middle cerebral arteries of various patients. But even though you have extracted these clots, it does not mean that the functional outcome of this patient is guaranteed. Again, we come back to the same picture. Now, these are 3 patients with left MCA occlusion. This was the patient we discussed in detail. This was the patient in which we saw that the contrast is staining only the gyral folds, the insular cortex, the frontotemporal operculum, the parietal lobe, and some part of it in the inferior frontal gyrus. Now, this was one situation, and we saw that this patient ultimately went ahead to have a good functional recovery. This was another patient in whom I showed that after MCA thrombectomy, this patient had just a staining of the deeper nuclei, that is of the caudate head and of the lateral putaminal region. Even this patient went on to have a very good functional recovery. But I showed you a patient in which at the end of the procedure, again, mind you, this is not blood. This is 130 Hounsfield. So this is definitely not blood, this is contrast. But this contrast is not in the gyrus. This contrast is not in the deeper nuclei. This contrast is stuck in the white matter of this entire left MCA territory. So the moment you start seeing this kind of a staining, you know that in this situation, the entire blood-brain barrier has broken down. What is happening in this case? Let us see. What has happened in this case is that you have had the artery which has taken the contrast. You have had leakage at very small places, only at the head of the caudate and the putamen. And then the contrast subsequently has taken the so-called lymphatic pathway and has disappeared. So the amount of blood-brain barrier disruption in this is very, very small. It is only at the deep nuclei. If you look at this case, in this case again, there is a leakiness of the blood-brain barrier. It is just leaky. But it is still maintained for the simple reason that the staining is only in the cortex. That means as the medullary venous system is passing through the deep white matter, that medullary venous system is still intact. The moment the medullary venous system, which is going from the arterial to the venous territory, is involved, at that point you will start having leakage of this contrast in the deep white matter territory, which is the drainage area of the medullary veins. First situation, this is again a post-thrombectomy angiovis view. Post-thrombectomy, the contrast has been injected into the internal carotid artery. The entire phases have been superimposed on top of each other. And what we find is that at the end of thrombectomy, we have the cortical veins as they should be, but at the same time, our deep venous system is also intact. That means after the MCA has been opened in this patient, approximately the entire blood-brain barrier of this MCA territory is intact, because the blood is going from the arterial end to the deep venous end without leaking. If it would have leaked, you would have had some staining in the white matter. So this is a situation in which there is minimal disruption of the blood-brain barrier. Therefore, this patient is going to do well. In this situation also, you have a complete skeletonization of the vessels of the blood-brain barrier. You don't see the capillary blush as you see it in this situation. But at the same time, the superficial and the deep venous system are again still intact. So now when the deep venous system is intact, obviously in this situation as well, the medullary venous system has not been destroyed completely. But there is no capillary blush being seen. That means that the blood-brain barrier throughout is leaky, but not broken, but not disorganized. So these are the patients where aggressive cytoprotective therapy is the need of the hour after mechanical thrombectomy. Come to the third situation. Again, you have injected in the MCA. And most importantly, this is color-coded for time. You can see that the amount of blood which is reaching the posterior part of the superior sagittal sinus, that is in purple almost. So that delay is at least more than 3 to 4 seconds when compared to this case. At the same time, you don't have any deep venous system, which is visible on this. If you do a posterior fossa injection, you will find the venous system. The venous system is there, but it is not getting opacified from the supratentorial area. So the blood is basically entering into the leptomeningeal angioarcade. From the leptomeningeal angioarcade, this blood cannot go into the deep system because the entire medullary venous system is broken. It takes a U-turn and comes back to the cortical venous system and then exits via the superior sagittal sinus. So if you are not looking for the deep venous system in these cases, on the lateral view of the angiogram, you will just see a delayed staining, a capillary blush kind of thing, but you will be very happy that your artery is completely open. But if you look carefully, the artery is open, but the blood is not taking the pathway that it was supposed to take. This is a patient who's going to bleed in the next 3 to 6 hours. So you have to be ready for decompressing this case. Now we have the capability in the cath lab itself. We do a CT on the table immediately after the thrombectomy. This shows you, again, this situation in which only the deep nuclei is staining. This shows you the situation in which the deep nuclei, you are seeing a staining in the gyral pattern. This shows you a situation in which you are seeing extensive staining in the medullary pattern. This patient will do very well, nothing needs to be done. This patient may do well, may not do well. This patient definitely will not do well. So the moment we finish the thrombectomy, we can make a prediction so as to what is happening. But is that good enough? Because we have already done the procedure, we have already opened the vessel, and now we are going to subject the patient to another procedure. So this made us think what else we can do to predict this even more earlier. So what we started doing is, this we have already discussed. What we started doing is, we started looking at the veins in patients with MCA occlusion. We have a typical 12-minute protocol at our center for doing the MR in ischemic stroke patients. Now, for example, all these patients, they go through a diffusion-weighted imaging, obviously ADC, T1, T2 flare, and they also undergo a susceptibility-weighted imaging. Now, in susceptibility, in patients with MCA occlusion, see, that is the thrombus in the M1. That is a small thrombus in the M1. Here, this is a higher cut, so we don't see that. Here, this is a higher cut, so we don't see that. So looking at the thrombus in M1 is of no consequence because we already know that there will be a thrombus. What is important is looking at the venous system, the deep venous system, which is going to be the outlet once you reperfuse this area. So in this patient, you start seeing a thrombus in the inferior ventricular subependymal vein. See, it is not there on the opposite side. Again, in this patient, you start seeing a thrombus in the subependymal vein. It is not there on the opposite side. In this patient, you start seeing a lot of thrombus in the PL veins on the surface, in the sulcuses. In this patient, again, you see a thick vein which is going to ultimately join into the internal cerebral vein. This entire vein is thrombosed. So what does this tell you? This tells you that because of the arterial thrombosis, because of slow flow through the entire arterial territory, the venous outlet has also closed. Now, if you have a closed venous outlet and you start opening the artery in this situation, what is going to happen? You're going to have a bleed. Because for you to have a successful reperfusion, you have to have a success of the same pathway which nature has determined for this patient. That means the blood coming from the top and going out, perfusing the entire brain, and then going out to the deep venous system. But if the deep venous system is occluded, you can be sure that number one, the normal pathway will not be followed. It will be a U-turn into the cortical veins. And number two, the hydrostatic capillary pressure in this area after opening the vessel may increase to a level where you can have a bleed. Let us see one example. This is a patient, 50-year-old male. He presented to us at 6 hours with right hemiparesis and aphasia. Small MCA infarct, ADC is reduced, M1 is completely occluded. This was a patient to whom we discussed in detail so as to what our results in this situation are. We told him that we can give we can do a mechanical thrombectomy. He was at the upper window for thrombolysis, so we were not very keen for that. But for some reasons, the patient refused. The patient was on conservative therapy. Maybe a dose of aspirin was given, a single antiplatelet. Nothing else was done. And the next day in the morning, we find this. Now, mind you, this patient has just received a single tablet of aspirin, probably, no heparin. This patient has not been thrombolized. No thrombectomy has been done. But at the same time, this patient also has had a significant bleed. Could we have predicted this? Yes. And this is what we had discussed with the patient's son the previous night. What we had told him is, we cannot deny thrombectomy when we see this sign. But at the same time, the chance of you improving with reperfusion are less. For multiple reasons, that you are at the upper range of the time window. This was pre-dawn and pre-diffuse, where we were not looking at 6 to 24 hours. We were not doing those cases. No MR perfusion was done in this case. So what I'm trying to say is, we have at least 30 or 40 examples of cases in which M1 thrombus is there, fine, that will be there. But the moment you start seeing thrombus in the deep venous system on the same side, these are patients who are likely not to do well. So these are patients whom you should try and stay away. ICAD, I think Dr. Mukesh will touch on it. I will not touch on all these. I will just bypass these. And I will just go to my final slide. Venous thrombosis, again, fine. This is which case? This is the angiogram of the patient whom I showed in the first instance. This is the patient first who refused all treatment, and he ultimately did well. He had very good grade 3 collaterals. He was jumping around, so we could not get good injections, but you can see that the collaterals are coming up till here. That's why he survived. So in our center, we just don't depend on a CT. We do this protocol for every stroke patient, and it is a 14-minute protocol which gives us all the information. We have this lined up, and the technicians are trained in a way that whenever there is a stroke patient, everything else is moved out from the table, and this is finished in 14 minutes. And sometimes we start the TNK and all in the MRI itself while we are discussing for mechanical thrombectomy. So if you summarize the angioclinical semiology, more the time that passes from the occlusion, the poorer is going to be the result. The more that time passes from the occlusion, the larger are going to be the core. If you give the patient endovascular therapy with TPA, the core is going to become smaller. If you give the patient endovascular plus TPA plus cytoprotective drugs, we believe that the core is going to become even smaller. So all these modalities, IV thrombolysis, mechanical thrombectomy, and cytoprotection, they are synergistic. Each of them give you maybe, some gives you 10%, some gives you 50%, some gives you another 5%. So added together, the effect is quite large. So how we do triage for patients in my center for intervention, we have two extremes. A situation in which we have very high confidence that the patient is going to do well, younger age, better comorbids, small infarct core, straightforward operative approach, and lower risk of complications. So these are the patients we try to push more and more for mechanical thrombectomy. The other edge, you have patients older age, worse comorbids, larger infarct core, complex operative approach, complex arches, and all those things. We try and tell them that definitely we will do the procedure, but the effect of the procedure on the outcome might not be so good. What we believe is that as of now, we are at this level as far as the treatment of acute ischemic stroke is concerned. We are at the most primitive mechanical level where we have a patient with a closed artery and we just open it. The next anticipated advances, as per what we think is going to be with the PL collaterals, maybe we can develop angiogenic factors which can mobilize the collaterals much faster. Simply increasing the blood pressure by 20 or 30 millimeters of mercury if possible, simply by hydrating the patient adequately, you can definitely use these collaterals for benefit. And the most important is going to be to harness the angiogenic potential of the lateral striate artery in the ventriculofugal segment. So this is where we are, and in the next maybe 5 to 10 years, probably this is where we are going to be. So with this, I think I'll stop this discussion on the philosophy of mechanical thrombectomy and how you can choose cases so that your results become better and better. And if there are any questions, I'll be happy to answer. Dr. Yanish.
Yeah, I have a couple of questions. What is the concentration of the contrast that you inject, which generates 130 ounce per units in the sulci? I mean, do you use half contrast or full contrast? Because full contrast. I believe that...
regular contrast, not diluted.
Non-diluted.
Omnipec 300.
All right.
See, if they reach up to the MCA, they are going to persist.
You have a very thorough and thought-provoking talk. What do we do about the venous occlusion? Is it concomitant? I have heard it for the first time. That is why I'm curious. I believe.
Venous occlusion, we believe, whatever we are seeing, it is because of the slow flow. You already have a prothrombotic state.
Exactly. That's one of the question.
In stroke, and on top of it, you have a territory where the blood is not flowing. Carotid T is occluded or M1 is occluded. So the entire M1 territory was supposed to be flowing into this vein. It is not flowing. So the chances are very high that it's going to thrombose because of slow flow.
Could it be that the same factor is working which is working in the arterial side?
Possible. Possible. But mechanical slow flow, we know for a simple reason that it causes thrombosis.
I think that is right.
Very interesting.
Microphone.
Gradient actually. That is the first image in which we can see the artery infarct, even before diffusion. Okay. So as soon as the artery is occluded, there is a slow flow in a venous stream. That you usually see. This is not the occluded venous stream.
How can we make it as a predictor of the outcome? That is my question.
Because that is what we are seeing.
That is his hypothesis. Right?
That is what we are seeing. If
I understand. Sorry.
if you have 100 patients with veins occluded and 100 patients with vein open,
So about
the chances of developing a reperfusion hemorrhage are much higher in the patients where the veins are occluded. Every patient will not develop a hemorrhage, but the chances are maybe 2, 3, 4 times higher. And people in Queen Square, they are doing some work on this, and they have also replicated this in primates. Humans, they have not reached till now.
The things is come in the picture only if the patient is having the low NHS score, okay, the mild deficit, and you see the good collaterals on angiogram, you want to intervene or not. If patient is having a significant deficit, means NHS score more than 6, whatever the collateral patient is having, you have to open up. And that patient is going to do better. So the collaterals comes in the picture. If patient is having, suppose NHS score only 4, you want to open or not. So we don't have the clear answer what to do on those patients, but if you are waiting, you may end up in the poor outcome. Okay. So if you are going to the CT perfusion studies, if there is a significant amount of the hypoperfusion in that territory, better to open up. And if there is not significant amount of the hypoperfusion, leave it. So that is like the 2 trials is still going on. Okay. Probably will answer for those. No. I'm answering for the questions for the collaterals here.
Two questions for the same thing. Like, so is this the reason? Like many times we see a stroke where even you give one, because even 75% bleeds. Some did bleed without giving anything, and then we think that we should have good that we did not lyse. So is this related? And second is the venous. This is uploaded. Then does it mean that IVT plus MT is better than MT alone, because it will take care of the venous pathology also?
So that's what the moment the techniques, the overall group-wise improvement improves. So maybe this is how it's working.
I think the most common factor which is how good controlling your blood pressure pre and procedure of MT. Okay. That is the most common actually factor. Okay. If you are not controlling the blood pressure, just immediately opening the blood vessels, there is a chances that open channels going to bleed. So till now what we know is to control the blood pressure around 140 or less than 140 once you achieve the TK3 score.
Sir, maybe this point could be rephrased slightly, no, sir? Maybe if we see a venous hypertension or possibly a venous stasis, we could probably predict that these patients could rebleed or could have a malignant edema, and possibly we can push them for an early decompression.
That's what I'm saying.
Rather than saying MT may not be beneficial.
That's what I'm saying. So see, the moment you start adding a procedure like a decompression, it is not a desired outcome. So what I'm saying is, I'm just saying it generically, that the moment you see this, you have to be on your toes. Because you cannot just leave this patient and come back tomorrow morning and see what is happening.
So you are... So at the MT, you do an angiogram and show that venous phase and demonstrate whether the deep venous systems are
intact or not.
That's the difference.
Exactly, you can predict according to him.
And then we could probably predict.
See, your neurosurgeon can be ready. He cannot plan a party in the middle of night. You will be ready.
And probably we can avoid antiplatelets.
And the patient will deteriorate from GCS 15 after that. So, or maybe 3. So, in these situations, maybe an early CP, an earlier CP, even 1 hour after the procedure. In this patient, maybe a tiny headache should not be ignored. He's probably bleeding inside. In this patient, you have to preempt. Allow things to happen. You have to preempt.
Especially if the patient is under GA, this will be a lot more helpful. Thank you.
So do you recommend not doing thrombectomy for such patients?
No.
We have to do in all the patients now.
But we tell them, or we tell ourselves, that the outcome in this patient is not going to be good. So that you are prepared.
But are we not going to the very basic thing now that even in large core we are doing thrombectomy now because the outcome is, so are we, why do we do all these scans now? I mean, just a CT, large core within 24 hours, we can still go ahead, even
Yeah,
review.
see, the practice also changes from place to place. In my place, it is not acceptable to the client. Thrombectomy here to 100%. So that's why we have to develop techniques so as to how we can fix it. Now you can use this technique the way you want in your setting, but this is the यहाँ पे एक DSA किया तो उसको लगता है वो दौड़ के जाएगा टेबल We'll not talk about that.
Sir, if I'm not mistaken, now they are also grading the angiograms based on the venous flow in the acute setting.
Now it has started. We've been doing this for 8 years. The last talk of the day, Dr. Mukesh, he will show you the mechanical thrombectomy and the techniques and all. He's a pioneer in this area, and we'll listen from him.